Ah, there is a button. Sorry.
Very small.
Yes. Oh, okay. For those who don't know me, I present myself. Okay. And I don't need to do an introduction of clinical case, for I don't think that you have people not companions. You are all here, and you know what we are doing with the clinical case. The only thing I ask you is to be short in the presentation in order to have a long discussion. We have many cases, and as you know, we have one day and also tomorrow morning clinical case. That means we outpass our usual day. So be short in order to have a good discussion. And please don't hesitate to go in the discussion. Important, as you know, the staff is to discuss the case. The two chairmen, Krzysztof, Oscar, you start.
So good morning again, ladies and gentlemen. Welcome at the first day at the Clinical Case Symposium of our annual meeting. It's my great pleasure to introduce, if ever, Oscar Andriani from Buenos Aires. My name is Krzysztof Zieniewicz from Medical University of Warsaw in Poland. So not to prolong the introduction, may I ask to the podium Guilherme Trallhao, please, to present his case. Hi, Guilherme.
Where is my... Well, good morning. Thank you for this opportunity to present a clinical case from Coimbra. So it's a woman with 53 years old, with some problems, mitral valve prolapse, some cigarette smoking, some alcohol consumations, with bisoprolol, with the medication bisoprolol. He came to your family medicine because asthenia and insomnia, without problems in the physical exam. And she did an ultrasound, and ultrasound showed a nodule with 5 centimeters in segment 6. And he did a MRI, and in this exam show probable adenoma or focal nodular hyperplasia. You can show you the exam in arterial phase, and you can see there, I don't know if, yes, this tumor, and in portal phase, the same tumor with probably adenoma. So he went to our department, no new symptoms, and in the multidisciplinary meeting, you show the exam, it's adenoma, or ulnar hyperplasia, no contraindications for surgical treatment, no need biopsy, so surgery. But some days after, he came with abdominal pain, with loss of 2 grams of hemoglobin, and she did an ultrasound, show a nodule with 10 centimeters. And a CT scan show a nodule with about 10 centimeters with a suspicion of recent bleeding. So he had a moderate hemoperitoneum. So you can see the CT scan, another nodule near this big nodule with some hemorrhage. So you can see the tumor with the hemorrhage, with hemoperitoneal. So surveillance to the patients, 4 days, no other hemorrhage, and after that we did a surgery with a bisegmentectomy, subsegmentectomy 5-6, with a Pringle maneuver with 10 minutes, yes.
Guilherme, do you want to go?
Just a question here. Yeah. So you showed us this lesion that was apparently whether an HNF or an adenoma.
Adenoma.
How can you be sure? So you had this MRI with arterial phase and the portal phase.
Yes.
So sometimes, if you don't have, for example, an MRI with primoviscs.
It was a primovist with this MRI. It's a primovist, and it was showed the exam with our Philippe Caseiro, you know, and it was probably adenoma. And the clinic with hemorrhage, it's okay with the diagnosis of adenoma. Well,
Pietro, did you want to?
I'm puzzled by the management, in fact, because she had the bleeding and then she was discharged from hospital without anything else after the bleeding to come to your surgery without anything being done in the mean?
yes, we did the surveillance. We did another scan, CT scan. We show you the scan. So it was the same diagnosis. So probably adenoma with hemorrhage near the adenoma. So when he went to the hospital, she did ultrasound and a new CT scan. And the diagnosis is the same.
Before management. Excuse me, but I saw the MRI before the management. About diagnosis, you said HNF or adenoma. Why not hepatocellular carcinoma?
Mm-hmm.
Looks very much like.
It's possible.
Yes.
It's possible because it doesn't like it is not like an HNF. You can get rid of that diagnosis.
Yes, I agree with you. It's the first diagnosis with medicine, with medical, family medical. But in our meeting, it was probably with the age, probably with no factors, etiologic factors to hepatocarcinoma. It was probably adenoma, but it was a possibility to be HCC.
At the beginning,
It's why you don't need a biopsy.
at the beginning of your presentation, you say you hesitate between 2 diagnoses. One, focal nodular hyperplasia or
Yes,
adenoma.
adenoma.
This was you say. My question is, when there is the bleeding, you may exclude focal nodular hyperplasia. Is it correct?
Yes.
I mean, at that time, you have adenoma and, of course, hepatocellular carcinoma. But
It was in
focal
yes.
nodular is today excluded
Yes.
at that moment.
In our
But you agree on the part. Is there is a risk of bleeding in focal nodular hyperplasia? I ask the question to all of you.
it's not. I
No.
think it's not.
No, I think also no.
Yes, Pietro.
Second question.
Sorry.
The second question is, by which sign you may, since the beginning, only of the image, exclude an hepatocellular carcinoma?
It's not excluded in our. But
No. I am generally speaking. Is it possible? No, I think yes, for focal nodular hyperplasia. You may be sure of focal nodular hyperplasia in which sign? When you have the central artery, I'll give you
In fact, there is. Okay. You have on simple MRI 10 signs. If you have all the 10 signs, which is the scar, the lobulated, and the enhancement, etc., if you have all the 10 signs, you can be sure. And now with Primovist and the long-term phase, it's possible to be sure that it is HNF. Maybe except if it's a man. You have to. When it's a man, we are always a little, well,
I
cautious,
enlarge
yes.
this question.
But
No, I enlarge
today
it.
it's possible to be sure.
In which nodule of the liver you may be sure only by image that it is a benign tumor. You have focal nodular hyperplasia and angioma.
And cyst.
It's all. And it's only these two tumors. You know, I asked this for.
Guilherme.
You know, I receive so many patients with, our doctor, our surgeon, it is probable to be a benign. And I say, probable is not enough.
Guilherme.
Cannot accept the probability of a benign tumor. Or you are sure 100%, or you may consider it is possibly, or the opposite, a malignant tumor. That means this is why I asked the question.
There is two signs here. One, it's some peliotic or necrotic changes since the beginning, so it is important to be studied a little bit further. And do you have some tumor markers, because you didn't mention?
Till now, no. But between the first and the second CT scan, a new nodule appears.
Yes.
I show you a new nodule near the. But you did the surgery, and you have hemorrhage. So after that.
Just a comment, please.
I'm sorry.
Lesion which was complicated, whatever the nature, HCC or adenoma, and it's bled. Why didn't you consider doing an embolization? At least it's a potential problem until she goes for surgery.
Yes, but it was stable. So
that's a potential.
it was possible to do the surgery. It was stable 4 days in our department, and after that, we programmed the surgery immediately. So I think it's not the question to did not surgery. It was stable, only 2 grams, and so hemodynamic is stable. So it's why you did surgery, not the embolization. It's a small hemorrhage. So.
Okay, let's continue, please.
So we did the surgery. 4 days to go to your house. Excellent evolutions. So you have 7 hepatocarcinoma. From between 4 millimeters to 9 centimeters. So no microvascular invasions. R0, so radical surgery. So, new multidisciplinary meeting. We did a scintigram, colonospitz normal, echocardiogram. You take some other exams, no new symptoms. You can see in November 21 and in January, we have recurrence. Four nodules, new nodules in the and I show you that after the So 3 months after, 4 new nodules in the, what you think, what you can do? So early recurrence with new for 3 months, 3 months after the surgery.
How old is the patient?
53.
53. So this looks like an aggressive disease, as you told. I think we can think about, in the future, we can think about the option of transplantation, but not now. But perhaps we could think about any kind of systemic therapy. For example, you have now a very good response to, for example, atezolizumab, and we may use this as a tool to select biologically this patient, and then offer it subsequently a transplantation.
Okay, so we start with levantinib, systemic therapy.
Why not chemobilization or CIRT?
I would say because it could be also good options. I think those could be good options, but I think we are looking at local regional treatments, and I think this could be a systemic disease.
Yes.
So this is why I would probably prefer a type of systemic therapy instead of a local regional one. But I think it's also a good option. Why not both? Or both. Why not?
But with the idea as a bridge to transplantation.
Everybody agree for both?
Yes.
No, I don't. I think we have to know if your treatment is efficient. So it's important to test the systemic with the target in the liver to see if they reduce. If you do both, you don't know. Yeah. And this patient has to be to have a curative treatment, so you have to know if you control the disease. So I begin with that, and after, yes, maybe to do, if you have a good response, I do a regional. Don't remember that she had a ruptured tumor. Yes. So it is a systemic disease.
Yes, it's a G3.
What do you call it good response? On biology of the tumor?
Imaging. You have only imaging here because she has alpha-fetoprotein very well, a little high, but not enough to have a response on that.
In our practice in New York, that patient would get probably chemoembolization for the interventional radiologists that are over 50 years old, and the younger ones would all do radioembolization on that, particularly targeting, I think they'd go on the right and then perhaps doing ablation of the smaller ones on the left. But if you're thinking that it's sort of a global disease, probably do the right side, radioembolization on the right, and then wait 4 to 6 weeks and do radioembolization on the left.
It's another option, but it was an aggressive tumor, early recurrence, young patients. So we start with systemic treatment. So, and we did a PET FDG. So the levantinib, it was well tolerated, and without in the PET FDG, I remember that it was a G2, G3 tumor. So PET FDG can be positive in some tumors. So we start with levantinib, and you show that the alpha-fetoprotein increase, and after that is better in the, and April 2022, the CT scan show only 2 nodules, and 2 nodules without active tumor. And you need a new PET FDG, and with reductions of all 4 lesions. So we discussed the clinical case in our MD multidisciplinary meeting. So we continue to do the efatinib with this response, and we do a PET choline too, because it was an indifferentiated tumor. So, and then you can show, I show you we compare the MRI January with the CT scan in April. So you can show no signals in the viable tumor in CT scan, and with the nodule of the segment 8, it's smaller, and no washout in this CT scan. PET choline, it's negative too. And you can show the evolution of alpha-fetoprotein. So the CT scan complete response in July 2022. What you can do now? So it's a good response.
How long do you want to wait? How long will you wait to propose a transplant if it's possible? How long?
It's now the question. It's now the question. We start the systemic treatment in January, and in July, 6 months after, with this response, we ask 6 months. 6 months, it's okay.
I have an opinion. Yes. In fact, from the point of view of the patient, now is the right moment. From the point of view of managing the grafts, it depends how many you have.
Yes.
So it depends on exactly on that. But for the patient, the right moment is now. If you want to wait longer, you do it at the expense of the chances of the patient and to favor the pool of patients who should receive a graft.
So,
Group AB, immediately. Group B, probably wait, because her graft would go to another person who needs it more, maybe.
What do you think about the rupture of the tumor? Could it preclude the liver transplantation? As Laurence said, it began with the rupture of the tumor. What do you think about that?
Well, that's exactly what I wanted to say, because this is a ruptured tumor in the beginning. You waited this long. Now you think that you have some sense of control, which is questionable, but at least in my opinion, it's a delusional thinking to say that this disease is completely controlled. I personally, if you even remotely consider transplantation, I would do a diagnostic laparoscopy to evaluate for peritoneal disease, because it's a ruptured tumor, and you know that PET scan is notoriously not helpful for detecting peritoneal metastasis. And you could also use, because you have 2 nodules left that are somewhat controllable, use that diagnostic laparoscopy as an opportunity to do an ablation at the same time if you don't find anything extrahepatic.
yes, but we didn't the last part.
What I wanted to say, I mean, okay, probably you've already made your decision. This patient has responded to treatment. That's number 1. We know it's high risk. Let's say compassionate transplant. I have 2 mandatory things. For this patient, you have to decide it will be probably a living donor liver transplantation, and or for the immunosuppressant, just because they won't need immunosuppressant after transplantation. Second, you have to consider what type of immunosuppressant regimen you're going to give. It has to be either sirolimus or everolimus because they have a carcinogenetic effect on the tumor.
Yes.
But you know that this patient, it is as a very high risk of recurrence.
Yes.
Okay?
No.
I would like to come back on the word rupture of the tumor. For, rupture of tumor, for some group, are formal contraindication of liver transplantation. For rupture of tumor means tumoral cell spread in the peritoneum, and this is contraindication. But in this case, we are not sure. It's hematoma. And you know what happened in this kind of tumor? There is a portal thrombus with hypertension, local hypertension, and sometimes you see the vein at the surface of the tumor, very large, and rupture. That means the hematoma could be a rupture of the vein due to the, and it is a bleeding. It's not a rupture of the tumor.
Yes.
Of course, it's difficult to part between these two, but I think the consequence of rupture of the tumor is contraindication. If it is only rupture of the hematoma, it's not the same. Hugo, you have something?
Yes, I was precisely going to say this because your quote on the rupture of the tumor being only rupture of the vessel outside the capsule, and in fact we have 2 cases of transplantation with rupture that never had carcinomatosis, and they are very, very long survivors. So we cannot exclude some of those.
Okay, we have to move on.
Yes.
We have to continue in the interest of time. So, Guilherme?
Yes, so I showed the evolutions, the same. So you repeated the tool, we repeated the PET scan, complete response, so we did a liver transplant. In Portugal, you have many donors, so there's not a problem with the livers. So he went in the list in the host, and it was transplanted in October. So we did the transplant. So it was okay, good evolutions. So on the histology, only 2 HCC viable, focal only. And it's a normal liver, the non-tumoral liver, it's normal. So you can see the alpha fetoprotein come low, normalize. And it's a CT scan after it was, everything it's okay. So you didn't show the carcinomatosis during the surgery. So it's so 1 year after the surgery, the patient, it's okay. So thank you.
Okay.
Now, general comment. Do you have general comment? No, I have a question, totally different. Laurence is an expert of benign tumor. Do we have some advance of the etiology of hepatocellular carcinoma on normal liver, apart neoplastic transformation of adenoma, which is one case, but we don't know, always.
There has been an epidemiologic study in France. There is an epidemiologic study in France with a large amount of cases, and we didn't find any, except tobacco, any factor. Just a last comment for that. I think you have to check on this patient in the long term, yes, because we all have those patients with very late recurrences. Yes. And just to be naughty, this patient could have been radiofrequency of those 2 foci, and be followed. It's very difficult because it's a bet, in fact. You have an aggressive tumor, but you have a very good response to the treatment. You have the rupture, maybe it's only blood and no cells, but it's very difficult, in fact, to have a decision. In France, for example, it's impossible to transplant this patient in 3 or 4 months. We have to wait 2 years now.
Yes.
2 years. So I don't think it's a bad thing to wait 2 years, in fact, in the waiting list. Maybe it's not so bad. But, well, check on this patient in the long term. I hope she will be okay.
You will do. Thanks.
I'm Katsunori from Japan. Thank you for your good presentation. And I think that, as you know, liver transplantation is very difficult in Japan. So the important thing is to maintain the liver function. And what I want to say is I'm sorry. I think the first imaging is hepatocellular carcinoma and rupture, but I'm sorry. So what I have to say is that.
You agree? You agree with this evolution or these decisions?
Yes, and because the rupture of the HCC is not equal to the dissemination of the hepatocellular carcinoma, but just a bleeding. So I'm sorry. It's okay. Sorry.
It's okay. It's okay. So thank you once again, Guilherme. Yes, of course. The last one and short, please, Rodolfo.
Just thinking about the seeding after tumor rupture. Some papers propose make the surgery before 48 hours after rupture, just to avoid the seeding, and wash the abdomen with water, distilled water. 5 washes during 2 minutes with distilled water, just to kill all the cells, possible cells, that will be the seeding after tumor rupture. What do you think about that? Because that is one thing that is contrary to wait the moment where the bleeding stop and the tumor come back to the original size, and you operate the patient when the tumor have the real size of the tumor itself, and not with the hematoma around. So what do you think about the wash the abdomen, operate before 40 hours after rupture, and do washing with distilled water?
Okay. What's your answer,
Guilherme? It's reported that.
I have no experience with this, but we did a study with our series, and we have not carcinomatosis. In all patients, we have rupture of the HCC in our series, not the big series, but never in 20 years or 25 years with Francisco Souza, we have not carcinomatosis in patients with the rupture of HCC.
Okay.
Only. But it's only in the it's not a big series, but we study that. So you have some metastases in the bone, in the lung, but in the peritoneal.
But no carcinoma.
After rupture of HCC.
But I had the cases.
Yes, okay,
I had the cases with seeding.
We have to close the case because we have another one. So sorry, we can discuss this in the break.
Thank you.
Thank you once
tonight. Move to Alessandra Cristaudi from Switzerland, who will present the next case.
Thank you for the opportunity to present our case. This is a 80-year-old woman in very good clinical status for her age that made some medical checks for urinary problem, finding this mass in the right liver, segment 6 and 5. She wasn't known for any chronic liver disease, so even if the contrastographic behavior of this mass was very suspicious for ACC, we performed a biopsy that confirmed our diagnosis, and she performed a liver workup, finding a NASH with a normal function and negative staging, and the alpha-fetoprotein was negative. So we performed a resection by laparoscopy with resection of segments 6 and 5 that was uneventful. She recovered very well. The final pathology was a PT1 G2R0. She underwent a follow-up until August last year when we found a relapse of disease in the form of this nodule in the abdominal wall. That was the only location at the staging with the thoracoabdominal CT scan, primo-vist MRI, and we performed also a PET with the Kalil that didn't find any other captation. So we went back in laparoscopy and found the nodule actually in the abdominal wall just next to the diaphragm. We excised it with a patch of diaphragm that was then sutured, and the pathology confirmed 2.5 centimeters ACC nodule that was excised R0. So the patient continued her follow-up until March of this year, where at the MRI there was a suspicion of a new nodule right in the top of segment 8 with a wash-in and wash-out that was not very clear. She performed also CT scan that didn't show any other lesion. Alpha-fetoprotein was still negative. In the suspicion of a relapse, so we performed a new laparoscopy using this time, as we weren't sure to really find the nodule and well identify the nodule. We decided to use the ICG camera, and actually this is what we found at exploration. We can see here the site of previous excision. So we found a little captation in segment 3. Then this is the abdominal wall in the site of the previous parietal nodule that was excited with a captation, 3 little points on the right diaphragm, very small. And that was the nodule that was seen on the MRI. That was actually also on the diaphragm. We also saw this little nodule on the peritoneum. So actually, we excised all the captation sites. So 5 parietal nodules, 1 peritoneal nodule, and a wedge resection of segment 3. And the pathology confirmed that all the parietal nodules were a little foci of HCC. Some of them were 2 millimeters, and no malignancy was found in the wedge resection of the liver. So about this case, there are 2 points that we would like to discuss with you. The first one is the possibility of a local seed in band laparoscopy. We think that what happened with this patient, this is not something that is really described in literature. The only thing I found was case reports mainly on urologic surgery, and the laparoscopy has shown a heavy benefit for HCC patient and cirrhotic patients. So I think the only thing that we can do is just be careful of careful handling. On the index operation, the tumor was not opened, was not ruptured, so we don't really understood why this patient made these local relapses. And the second point is the use of the ICG for this kind of surgery, which is something that is very well established by now due to the very quick half-life and the different phases that we can use for the HCC as the biliary phase and the parenchymal phase. There are many ways that you can use the ICG for the preoperative workup for clearance, biliary anatomy with cholangiography, positive and negative staining during the parenchymal transaction, and to better localize capsular lesion. So it wasn't really clear if we could use it also for extrahepatic tumoral recurrence. And this is something that colleagues from the Tokyo University has already described with a very precise localization of all extrahepatic and nodal localization of JCC that also in our case was very precise as we found 2 millimeters foci. So that was quick.
Thank you, Alessandra. There is some question in the audience. Hugo? Yes, Eduardo.
Yes. Nice presentation, but my question is, why do you think that laparoscopy liver resection is the cost of the implantation if you previous has a biopsy of an HCC, and when you biopsy an HCC, it bleeds, and it's seeded?
That was...
Why you don't think previous in the biopsy nor in the liver resection?
That is a possible explanation.
That's possible. We do coaxial biopsies and plug it. So our radiologists swear that's not them.
It can fail.
It can fail, yes. But you can argue, should we biopsy this kind of tumor or not? We have the practice to biopsy them, and these kind of recurrences are, in fact, extremely rare. So we see them absolutely anecdotal. This is a possibility, but the other possibility is seeding at laparoscopy, and that is seen. Or trocars, implantation at laparoscopy.
Hugo, and then Jina.
I agree with Eduardo. I think you have a previous biopsy, even if it's protected, it's not completely bulletproof for recurrence. And on the other hand, we don't have any evidence for HCC that this happens in the literature, at least from my knowledge. There isn't any. And on the other hand, it's not a port recurrence, it's a local recurrence. So I wouldn't blame pneumoperitoneum on this, unless there was, for example, a rupture during the resection that I'm sure that wasn't because it didn't mention it. So I wouldn't say, and in fact, we sometimes see, not very frequently, but we sometimes see those patients with carcinomatosis. Second question, when did you inject ICG?
The day before.
How much, what quantity?
0.5 milliliters per kilo. When? The day before, 24 hours before.
24 hours.
Jina, did you want to? Okay. Juan Pecol.
The conclusion is you recommend for each case of resection of hepatocellular carcinoma to do 2 days before the test.
We are doing this now. Nowadays, we are injecting the ICG to all patients with ACC to better localize and eventually find other localization that were not seen in the preoperative images.
An important recommendation. Everybody agree for that?
If you would recommend to inject ICG, to use ICG for all patients that got for HCC surgery?
What we are discussing, yes, it should be good, but our experience in practice is that we actually don't see this so well as you are seeing here. When we use it before, we cannot have such good quality images.
Okay.
That is why I was
in
asking
robotics, you have the firefly
Yes,
in the
we do.
machine, so that is really easy to
Okay.
use.
Juan Pecol is waiting.
Yes.
Thank you.
Maybe you go, the quality of your image during laparoscopy or robotic surgery is related to the timing between the injection of ICG and to have the quality you presented, maybe 2 days before surgery give you a good imaging.
One?
Talking about the recurrence, you show a CT scan where the biggest recurrence was in the diaphragm. So, and I suppose that this was the way where was the needle for the biopsy. So I think that for this reason, we are not so happy to do previous biopsy. Also in the patient that are going to liver transplant, we contraindicate but here is the place where was the needle.
What said Pietro about the coaxial biopsy? There is no risk if we follow the technique. The technique was described by Marc Johan initially. You know, we were the first, I think, to propose this in Paul Proust. But the technique we use by the double needle biopsy, coaxial, and to plug after there is no risk. So, no, really, I think we must discuss about this technique.
No, this is no risk, but this is probably what happens. So we have to believe what we see rather than what we think. And this was, of course, our first culprit. But the radiologist said no technical errors, no glue inside and everything. So, but Eduardo, as always, says that it may happen even with that.
No, but the use of the ICG is really very convincing, and the pictures are amazing. So I think it's really difficult to repeat it.
It's not difficult to replicate it. We see this quality of picture. They see because they're
with quality, probably.
Is possible a question for?
Yes, of
we're
course.
Short of time. Pietro, in your experience, did the biopsy change in anything the attitude you will have with this patient?
Yes, I do. We had a very similar tumor, exactly like that I will show you next year, in which it changed a lot the preoperative investigation and discussion with the patient. And well, I can tell you now, it was a high-grade neuroendocrine, absolutely undistinguishable from hepatocellular carcinoma or adenoma, in fact. And the patient insisted on, she did not want to be operated because she thought it was a benign tumor, and I insisted on the biopsy.
But you said that you biopsy all the patients. And if the case is that you have a patient with a tumor marker high, the patient has a liver disease and has a tumor, what is this?
That we don't biopsy. That we don't biopsy. I mean, if we have the Barcelona criteria for diagnosis of hepatocellular carcinoma, we don't biopsy. But we have to have all the criteria. This patient did not have the criteria. She had just a hypervascular tumor in the absence of cirrhosis, in the absence of risk factors. So this is why we biopsied her. But if she had 600 of alpha-fetoprotein, we would have not biopsied her, of course.
Okay.
Any other question or comment? No? So once again, applause. And we're moving to the next presentation that came from France, from Bordeaux, I suppose. Laurence Chiche and Jean-Philippe Adam, s'il vous plaît.
Thank you. Thank you. Good morning. I would like to thank
Thank you, Professor Torzili, for this beautiful meeting. Thank you, Professor Bismuth, Hugo, and dear companion. It's once again a pleasure for me and an honor to be here and to share this case I call an unusual hepatic cyst in hereditary syndrome. It's a case we took on with Laurence recently. It deals with a 52-year-old woman. She has no comorbidities, but she is known to have a von Hippel-Lindau disease with a long follow-up. As you can see, she underwent surgery in 2008 for hemangioblastima. And at this time, on the CT scan, as you can see, and as 1/3 of patients with von Hippel-Lindau disease, she had a serous pancreatic cyst, which involved the whole pancreatic gland. And recently, in April, she came to us for a consult because she wasn't feeling very well. She has lost 5 kilograms over the 3 last months, and she complained of epigastric pain and dyspepsia with nausea. A CT scan was performed, and I'll let you discover the CT scan. There is a huge multicystic lesion. And my first question to you is, what is your opinion about this cystic lesion? Yes. No.
So we see this a lot in the pancreas, in the von Hippel-Lindau disease, but not so much in the liver. Do you have an MRI?
No. No MRI was performed.
Philip, does it has contrast enhancement, the cyst walls?
Yes, I will see after. I show you that there is a strong arterial enhancement of the wall cysts.
I would perform an MRI and see the behavior on diffusion. I think it's probably you have at least oncologic disease here, or a probable one.
So you think the MRI helps you to take a decision about this lesion?
Yes. But with the contrast enhancement on the CT, it's a worrisome feature even in the liver, like in the pancreas.
Okay,
I will think in this case in intraductal papillary neoplasm of bile duct. This is one of the diagnoses, and the MRI will add any substance in the diagnosis.
Yeah, sorry, I agree. I think there are two things. This looks like either a cystic adenocarcinoma or an IPIMN-B. And the only thing that distinguishes them is the presence of struma ovari in the first one. And imagologically, they are the same. But you can see, for example, diffusion, restriction to diffusion in the nodules, or hyperenhancement in the arterial phase that are suspicious of malignant nodules inside the cysts. I would say this is one of the two things.
Okay, so the problem is for this patient, it's not possible to perform MRI. So we just have the CT scan.
She had brain surgery, it's impossible, with material inside, so no MRI.
Any tumor markers?
They were normal.
Normal.
All the markers were normal. So you talked about intraductal papillary neoplasm or mucinous cystadenoma. Just I give you one information we had during the consultation is the imaging in 2017, and as you can see, this cyst still existed, but was very with a little size compared to the situation now. So how would you manage this tumor? By the fact that we couldn't perform MRI. So will you consider, yes? No, no.
Is the option to make the diagnosis about this pathology and try to, because you have all in one, you have the possibility to see the change inside the duct, to see the mucin inside the duct, and to take a biopsy. And that is a recommendation to rule out the IP, intraductal papillary neoplasm.
Yes, but we saw that it's an aggressive exam for lesion for which we are not certitude that there is a communication with the bile duct.
But
so there is a risk of pancreatitis in a patient with a...
But now is a recommendation, even
I'm sorry, but it's not right, because if it's a mucin carcinoma,
what is not right?
That is a recommendation to do such an exam before that type of tumor, which is not communicating with the biliary duct.
But you already know that it's no communication. One thing that is important to prove is the communication with the biliary tract, and this one is one possibility. And even one thing else is that if you take a biopsy, you make the differentiation between what type of intraductal papillary neoplasia is it, because it's recommended to be more aggressive in type 2 from the new classification from the WHO 2019. So I'm recommended to do a cholangiography just to rule out that.
Okay.
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 So I think that there is a possibility. Intraductal papillary has a cystic form, and these cystic forms, you cannot show a communication with the bile ducts.
Yeah.
So I think it's difficult. But on the other hand, they can be multifocal. Ideally, it would be an MRI. You can do an MRI. I would probably propose, but I think, in fact, either option for this patient, the therapy is resection. So I would go for resection. I would probably do, to be sure, an intraoperative cholangiogram to rule out multifocal disease.
Okay.
But I would go to resection.
Okay.
I think that any other study will not add. I agree with Rodolfo. Maybe many people speak about spyglass or whatever, but it will not going to change what you have to do with this patient, because you have not many opportunities to resect. The cyst, one of the cysts, is close to the only hepatic vein you have that is the right one. So you have to go to surgery.
We will agree with your comment, Professor Santimanias. Negative. And in this presentation, there were some worrisome findings. The first one, as you can see, is the increase in size of the lesion and the transformation with the years. The second one is, as you say, the strong arterial enhancement of the wall cyst, and the presence of heterogeneous and a tissular part inside the lesion. And the fourth one is the context of von Hippel-Lindau. And we know there that there is some genetic mutations which could lead to the development of benign or malignant tumors. So for this reason, as Professor Santimanias said, for us, as a pragmatic attitude, we planned for a resection of this lesion. As you see, for us, there is a contact with the trunk of the middle and the left hepatic vein, but the right hepatic vein seems to be not involved. So we plan for a left hepatectomy with caudate lobe resection and part of segment 8. The volumetry was favorable, and Lawrence did surgery. As you can see on the left, the operative view. Sorry. and the picture related with the specimen. And if we just have a look of the specimen here, as you can see, there is some proliferative mural nodule. So the fear that probably it was a degenerated lesion. So our surprise, and we were embarrassed, and the pathology report was disturbing for us. As you can see, pathologists described it as a serous cystic neoplasm of the liver. The resection was complete, but pathologists could not distinguish two possible diagnoses. The first one is a primitive liver serous cystadenoma, and the second one is a liver metastasis of serous pancreatic cystadenocarcinoma. So apparently, it... No, no. I will discuss it later. I don't know.
Wait a minute. Wait. Let him finish. Let him
the
finish.
pathology. We took a phone because we didn't understand this report. So the pathologist told us there were no signs of malignancy on the analysis, microscopic, immunochemistry, no signs of malignancy. So we didn't understand why it was a possibility of a metastasis for us.
Jean-Philippe.
And
the pancreas was not healthy. Did you explore the pancreas during the
at this time? At this time, no. At this time, no. But
ultrasonography or something.
The other confident element is that the pathologist could not distinguish both diagnoses. And to be honest with you, I didn't know this both diagnoses.
Oscar, can I have
yes.
your micro, please? Just to rule out the liver cirrhosis cystoadenoma, sorry, the mucinous of pancreas cystoadenoma, just to rule out the presence of the ovarian stroma. This one is the thing that makes the difference. So with that, you rule out the presence of mucin cystoadenoma.
Oh.
And after that, you have other possibilities. One is the cystoadenoma, but the cystoadenoma is no typical, serous cystoadenoma is not these typical images. So I think the other possibility is, again, APMB,
yeah.
intraductal papillary neoplasm of the bile.
Yeah, but pathologists were collegially sure that there is one of both lesions because they were described in the literature. Yeah.
Malignant disease in the pancreas. It's always
apparently no.
Yes, and why they suspect that?
Because it was described, and I show. So it was described. So among the subtypes described of serous disease, I mean serous disease, you can see von Hippel-Lindau disease-associated cystadenomas, and usually it's not mandatory to perform a surveillance or follow-up for a patient we saw with pancreatic serous cyst, even if it can grow, even if it became symptomatic. But I was wrong. As you can see, serous cystadenocarcinoma was described, and in the literature, you could find less than 20 cases with distant metastasis. The problem is that malignancy, according to the definition of the World Health Organization in 2010, malignancy is defined where there is distant metastasis. And I found the needle. There is one case after a few hours of research
one case of a patient, a woman with von Hippel-Lindau disease, who underwent surgery, partial pancreatic surgery for cystic serous neoplasm, and 4 years after surgery of the pancreas, she developed, as you can see, several nodules, and these nodules were resected, and at the pathology, the findings were similar. So they describe this entity, which is extremely rare, okay? This is another example described outside the context of von Hippel-Lindau disease with pancreatic cystic neoplasm and a nodule in the liver, which is resected with the similar findings. So maybe it exists in your head, but as you can see, the nodule were different from our nodule. And I agree with your worry about the IPMN liver lesions. And with Lawrence, we don't think this is a liver metastasis, as this lesion still existed many years before surgery, and maybe it is a previous serous liver cystadenoma. And actually, you describe it, you go in this publication in 2005, maybe it's a kind of cystadenoma, but non-mucinous cystadenoma, non-cystadenoma with stroma-like mesenchymal stroma, but only serous.
Yeah, but that was my question. So, but you are assuming that because you have a cystic tumor on the liver that could be similar to the one on the pancreas, that it is a metastatic lesion. But for example, in this paper we saw percentage of malignancy in cystic tumors is around 30%, can reach up to 30%. Yeah. But why is this not a simple cystic papillary intraductal tumor without malignancy? Why is it not a primary tumor? Yeah. And it's not so rare, it's more frequent.
Yeah. I agree with you. And so the question is, should we consider pancreatic surgery? No. Our feeling is no, but...
Okay, I know it's disturbing because you can't imagine how long I discussed with the pathologist, because I agree with you. I was sure it was an IPNM because it looked light. But we have excellent pathologists in Bordeaux, and they said, well, I put my two hands, it is not IPNM, it is not mucinous, no ovarian tissue. In fact, we present this case because I thought, first of all, that, and that's what I said to my pathologist when she said it's a serous cystadenoma of the liver, I respond, it doesn't exist. And they say, yes, it exists. Okay. In von Hippel-Lindau, the problem is, and Oscar, you said it, she had a lot of serous cystadenoma. We know that, and we know that it's a benign disease. In fact, well, we have to be cautious because it's not always benign. And what I saw, because she had a follow-up, so we had a lot of CT scan, and the pancreas is not changing at all. Only this tumor. And I think that this tumor is a primitive tumor. It's a cyst in the livers, in a serous cystadenoma of the liver. I didn't know it exists, so well, it exists, and it's not mucinous, it's not IPNM, it's another diagnosis, extremely rare, of course, but we are a little concerned about the pancreas because she said that perhaps it's metastatic, but I didn't know that a benign tumor can be metastatic. So I think it's, of course, very rare, but it's interesting case for me.
What's your idea for the follow-up of this patient? How often and what kind of examinations you propose?
I think we will perform a CT scan in 2 or 3 months. The point is that we discover a spinal hemangioblastoma, donc she needs to be taken by a neurosurgeon for a new surgery.
Any other questions or comments? If no, so
thank you.
Congratulations. And now I would like to invite to the podium Oscar Andriani from Buenos Aires, Argentina. And Oscar will present the case on...
Thank you, Krzysztof. It's rather a short case. So it's a recurrent liver metastasis from colorectal cancer. A male patient, 49 years old, in March 2019. A sigmoid cancer with a synchronous liver metastasis was diagnosed. You can see the primary here, and some scattered little metastasis in the MRI. This is the scheme of the position of these metastases. One of them was deeply in the right liver. And in April, he underwent a laparoscopic left colectomy. The anatomopathology was a G2 adenocarcinoma, PT3, N1, M1A, and RAS wild type. So we planned a perioperative chemotherapy with FOLFOX6 between May and August. Then he underwent liver surgery. Some metastases disappeared, and this is like they looked at the time of the planned surgery. And in September 2019, parenchyma sparing hepatectomy was performed with multiple liver resections and the radiofrequency ablation of the deep metastasis in the right lobe. You can see some images here. So 1 year after, liver recurrence appeared. One of the lesions was one of the disappeared metastases. The other one was near one of the resection. And in the diffusion sequence, you can see better the location of these metastases. In PET scan, you can see several ones that couldn't be detected with other methods. And a FOLFIRI bevacizumab chemotherapy was introduced. Irinotecan was needed to be interrupted due to toxicity, and it switched. The scheme was switched to capecitabine and bevacizumab. Unfortunately, the patient didn't came back to the surgery consultation and was follow up only for the oncologist. And the chemotherapy lasted at least 1 year. So after that, the patient came back, and we saw several liver metastases, mostly of them in the right liver, the right lobe, and an ALPS procedure was planned. In August was the first step. In between, the EVA index was 31, so we went ahead with the second step. 3 weeks later, you can see here the specimen, and other lesion in the segment 3 was also removed. In February 2023, a second liver recurrence appeared in the liver remnant, and radiofrequency ablation was planned. You can see with several needles. Our interventional surgeons performed these 2 ablations, but very rapidly new lesions appeared. One of them in the bed of one of the ablations, and the other ones are two new lesions in May 2023. The PET scan showed only liver recurrence. No further lesions were found, and you can see in these reconstructions all the lesions. And these 2 ones are the more complicated to planned a new surgery. You can see here the contact with the bile duct and the contact with the portal vein. Here, the portal vein, one of the tumors, and the other one which is anteriorly to the left bile duct. So in summary, in March 2011 of 19, it was a synchronous liver metastasis. In April of the same year, he underwent a left colectomy, perioperative chemotherapy, and in between the parenchyma-sparing hepatectomy. 1 year later, the liver recurrence, which was interrupted the follow-up, the surgical follow-up, and he retook this follow-up 1 year after, and an ALPS procedure was performed, and rapidly he had 2 recurrences, one in February and the other one in March after the radiofrequency ablation, in May, sorry. So what to do? Do you think that it's advisable a new surgery, that perhaps it not be a radical surgery, or it's a good candidate for liver transplantation? It's a left colon cancer, RAS wild type. The CEA is lower than 80. The metabolic tumor burden is less than 70 cc, and it's a liver-only recurrence. The problems are perhaps a rapid progression, and it was initially a synchronous liver disease.
I have a question, Oscar. All we know that synchronous liver metastasis of colorectal cancer is a bad prognosis factor. Why did you not start with chemo instead of go to the colorectal first and then to the liver? Why don't you start with the chemo and then decide if you perform a simultaneous resection, whatever? That's one. Maybe this patient has had the disease all the time and had been treated. So maybe one, I don't know if it has been studied with what about the stability of the tumor?
He's proficient. He doesn't have instability. He's stable. All the proteins are stable.
And the disease was all the time in the liver. So I think transplantation is one of the options. But I think that this patient has bad prognosis.
Regarding your first question, Eduardo, the patient was referred to us after the colonic surgery. So I think, as you, that it should be better to perform preoperative chemotherapy and then decide what to do with both sides of the tumor.
Any other questions or comments, Jina? Take the microphone.
I agree with Eduardo from the beginning. He belongs to the group who will recur again and again because of his oncogenic type. But I would have started with chemotherapy today. The question is why not consider local therapy, just intraarterial chemotherapy. I'm not sure he will be a great candidate for transplantation, in my personal view, because I have the feeling he will develop metastasis afterwards. Mm-hmm. So it's not a good group for whom I would offer chemotherapy, transplantation.
Just a question, Oscar. Is he responding to chemotherapy now?
He is under chemo. He is now re-exposed to FOLFOX and cetuximab, and we will see what happens. If he remains stable, our idea was perhaps to propose transplantation for.
Because if he responds, you would have 0 Oslo criteria for transplantation, which means he could be in the group of more than 70% 5-year survival.
Because
Because he has 0 criteria. So
if you look for the Oslo criteria, he's 0.
So he has a good prognosis after transplantation if he responds.
If he responds, absolutely.
And besides that, he's a RAS wild type, he's a left colon, his CA was never above 80. I think it's an option.
Okay. Valerio?
Very nice presentation, thank you. I would be very cautious in proposing liver transplantation. In my point of view, I think the risk of recurrence after transplantation might be very high. I don't think we can rely on this, on the Oslo score in this case, because he has very fast, you operated on him already 3 times, he recurred very fast afterwards. But I had a comment on the location of the metastasis. You have one location which is surgically non-resectable because around the Rex ligament, and in probably our radiotherapist would propose a stereotactic radiotherapy to this metastasis. I don't know the results. Somebody of you have an experience on this? Because we would eventually propose radiotherapy on the unresectable metastasis and re-resection on the resectable.
You mean SBRT?
Yes, SBRT, yes.
What I think is, of course, he is recurring pretty rapidly, but it's only in the liver. I would say the only option that he has, if you have the livers for this, transplantation is his best chance. If you have the liver for this, but
or if you have a living donor. I think in no country, in our countries, nobody has enough livers for everybody. So,
what would you consider a living donor for this?
Eventually, I wouldn't now, because very rapidly progressive, and I don't think that I would wait for definitive, more solid.
I would say.
No, but it's perhaps a possibility, yes. The only problem is that I don't know. It's very close to the biliary duct, the bile duct. The left bile duct is almost in contact with one of the lesions, and the other one is in contact with the left portal branch. So I don't know if it should be some complications with the radioembolization, but perhaps it should be a possibility. I think we are waiting the response of the new chemotherapy. I don't mean to transplant him now. I mean, if he's stable with this folfoxcetuximab scheme, afterwards we can perhaps, if there is no progression, to propose. But I don't know. I'm asking for your advice that are really very experts in the subject.
Oh, I think that it looks like a good proposal in this case, to wait for the efficacy of the chemotherapy and then taking into consideration the 0 Oslo score, maybe FANG is also very low, so there's still a chance, Valerio. I know that you don't agree.
They changed in the last study the interval from primary tumor to transplantation for 1 year now. So they are using an increasingly a lesser interval for this.
Mm-hmm.
Okay.
Okay, thank you.
We have one more. Any questions, sir? No. We have one more presentation. Thank you very much, Oscar. I would like to ask to the podium Rodolfo Russi from Argentina, from Buenos Aires, to present his case. Rodolfo, please.
Okay, nice to see you again one time. Thank you, Guido, for the organization. My case is about a woman with 64 years old, with history of cholestasis with jaundice 1 year before. She went to the hospital due to that, and CT scan and MRI was performing, showing a liver tumor and choledochal dilatation. I will see you there. You can see here the choledochal dilatation, and the tumor on the right side, this tumor, in contact with the right hepatic duct and almost with all the right hepatic pedicule, and in contact with the gallbladder too, as you see here. The gallbladder was completely normal, no thickening wall, no stone inside, and no evidence of a stricture on the extrahepatic biliary tract. So you see here the MRI showing the same images, but some other findings. For example, this enhancement inside, and these other images, a spheric image as vesicle, maybe, why not? And this other maybe solid image inside, this zone of enhancement on the wall, inside part of the wall of the cyst. So you have here another cat showing almost the same, the gallbladder, the tumor. This a cystic tumor, a predominant cystic tumor, but with some heterogeneous content inside. As you see here, again, this spheric image is inside, and a solid one right here. And on the T2 time, the same. So many liquid inside, but with solid formation maybe. The gallbladder, the cystic duct, the choledochal dilatation without a stricture. And this was a report, the official report, segment 5 tumor, subcapsular formation, polylobulated with septate inside, hypointensity on T1, hyperintensity on T2, surrounded by capsule or pseudocapsule with heterogeneous liquid content and with area of mural enhancement in contact with the gallbladder, hepatic artery, and cystic duct. So the patient had done to a marker that was completely normal, and all this situation of cholestasis with jaundice disappeared spontaneously in 3 days, doing nothing. And the patient decided to leave the hospital because she had no clear diagnosis about that, and she started looking for another opinion during almost 1 year. And 1 year later, I arrived to my consultation, completely asymptomatic with normal liver blood test, with performance status 0, asking me, Dr. Russi, what is that and what to do with that? And I transfer to all of you the same question. What is that and what to do with that? So during this period, before arriving to my consultation, he had an hydatid serology. You know, in Argentina, we have many hydatidosis, and sometimes the hydatid cystic have a connection with the biliary tract and release vesicle and can do some transitory obstruction, as this patient had. But was negative. Even if negative, you can have hydatid cystis. So, of course, I ordered a new MRI and a new cholangio MRI. And I will show you this new MRI that show almost the same, the tumor on the right liver with cystic look, with these images maybe inside, this vesicle, or cylindric with spheric images inside, in contact with the right hepatic duct, maybe with the right hepatic artery and right portal vein, as you see here, in contact with the gallbladder. Here. You have a coronal cut just to see that the tumor was almost extrahepatic. More cuts right here, the same, heterogeneous look, this formation inside, and you have here the diffusion time that was cap restriction and lost the signal on the ADC map. So maybe have something solid inside between the liquid. So you have here a cholangio MRI. Cholangio MRI show this formation, again, this is polylobulated, but cylindric formation in contact with the biliary duct, apparently connected with the right hepatic duct, as you see here. And this, again, this spheric formation, no? So you can see here the same. The coledocal now was decreased the size, almost normal, have 8.9 millimeters. You remember before have 14 millimeters. And you have here another nice pictures that show some connection here, apparently, with the right hepatic duct, the same right here, in contact with the gallbladder, polylobulated, these cylindric formations. No evidence of stricture of the stricture of the coledocal. So at that moment, no explanation about which was the reason of the partial cholestasis that she had. You, Laurence, you are looking at me, you have the diagnosis already. So right here you have another view from up to down, and here you can see the connection apparently with the right hepatic duct, and you have here a coronal cut that shows some content inside this solid image apparently. And the official report spoke about segment 5 tumor in close contact with the gallbladder, polylobulated image showing communication with the bile duct, right hepatic duct, heterogeneous areas with enhancement inside. It is associated with a slight dilatation of the adjacent bile duct. The common bile duct now have 8.9 millimeters, also almost normal, low cystic insertion, and the image described is in close relationship with the portal vein and the hepatic artery, all that we speak before. So now I wait for your opinions. What do you think about the diagnosis? And what to do with that?
Eduardo and Hugo.
Understand now why you wanted. Yes. In fact,
we have no at that moment.
Yes, I understand now all the discussion before. But, you know, she had a jaundice, and I think it's a migration of a tumor before, and it's when it's communicating like that, because it's proximal, it's understandable. She had a jaundice spontaneously regressed because the tumor or the bleeding, whatever, is the explanation. So for me, it's spyglass, yes, it's a good idea. Yeah. If you want, absolutely. But personally, I think it has to be, well, removed. So I would go to surgery.
And about the diagnosis, you've seen that it's a IPNB.
Eduardo.
I agree with Laurence, but I think that in this case, not the before, this case, need spyglass because you need to know if you have papilla, if you have dysplasia in the main bile duct, in order if you have to associate to the liver surgery a duodenopancreatectomy, if you want to be radical.
Yes, and even rule out other location inside the liver, even.
Rodolfo, for me
and take
also,
a biopsy, you will see after.
For me also IPMN-B, biliary IPMN, most certainly. The best way to see if you have multifocal disease is usually by MRI, because with cholangioscopy, you can only go to the main bile duct and the main ducts afterwards. The place where the multifocality is more frequent is the gallbladder, that you will remove, of course. And I would do cholangioscopy according to the reason Eduardo said. But
perfect. So, any comment else?
Yes. We had quite a similar patient. In fact, he proved to have a form of cholangiocarcinoma with multiple papillary forms inside the duct, and the main formation was very similar to that. But I come to Eduardo's. Now, if in this patient you show that you have dysplasia in the bile duct or in the pancreatic ducts, do you think that she would need now such major surgery rather to have the problem dealt with now, analyze it, and then follow up. I think this is what we would do.
Okay.
Yeah. Ugo.
A patient with a very similar situation, and we were not sure that the distal bile duct had disease. We first performed a left extended hepatectomy. 2 years after, we discovered a tumor in the distal bile duct, and then we performed a pancreatic duodenectomy.
Yeah, but not right
At the
now,
same
at the
time,
moment, the
because it
whole
could
big
be
lot.
prophylactic also.
It's a bit excessive. The patient, in fact, doesn't seem very easy to persuade to surgery in a way. It took a long time for a second opinion.
Shall we continue?
Yes.
Rodolfo?
Okay. We thought about many possibilities, as this one, complicated simple cysts, parasitic cysts, cystoadenoma, cystoadenocarcinoma that we spoke before, and of course, intraductal papillary neoplasm of the bile duct, maybe others. And what to do about that? We offered, we speak with the patient, we spoke with the patient, and we say that we thought someone of this one could be the diagnosis, and the surgery was necessary, even especially thinking about all the obstruction, the biliary obstruction that she had before, and all of that. So we proposed the surgery, the patient accept, and we went to the surgery, and on the surgery we find this tumor beside of the gallbladder, almost extrahepatic tumor, as you see here. And we performed a cholangiography through the cystic duct, as you see here. And the intrahepatic biliary tract was normal, the extrahepatic biliary tract was just with a little dilatation. And you can see here the communication with the tumor, apparently from the right hepatic duct. And the extrahepatic biliary tract was completely normal, no restructure. So apparently the transitory obstruction was a cause of this tumor that released something inside. So we resect the tumor, we liberate the tumor from the neighboring structure. It was easy to do that. And we find this duct that make a connection from the tumor to the biliary, to the right hepatic duct. And we perform a cholangiography through this duct, and was the same from the cystic duct, which was connected with all the biliary tree, with the right hepatic duct, as you see right here. And we take a sample from this duct just to frozen biopsy, and the report was no tumor inside, was normal tissue. So we finished the surgery, we resect.
So, Rodolfo, just one thing. This could be mucin, for example. In this type of tumors, you have a lot of times the bile duct filled with mucinous substance. Sometimes we do, whenever possible, we do intraoperative cholangioscopy. That is very useful in these cases, I think.
Yes, but yes, that was happened. You will see that. So we finally we finished the surgery right here, and we make again a new cholangiography through the cystic duct just to rule out some leaks. No evidence. So the final surgery, and you have here the specimen, this cystic tumor with this connection that was the place where in connection with the biliary tract. And when we open the tumor, we find this formation inside, that you see here. And of course, now the question, what is that? And the report was intraductal papillary neoplasm of the bile duct associated with invasive mucin carcinoma. According to the WHO classification from 2010, 3 diagnostic criteria are necessary to make this diagnosis. Well, the one is papillary structure compromise the bile duct. So you have here the papillary compromise, the normal tissue and the papillary compromise. Second, the absence of ovarian stroma, just to rule out the mucinous tumor. And you can see here, no ovarian stroma. And the last, the communication with the bile duct. You have here the communication with the bile duct. So, and you can see here a scheme about that. This is a picture under electronic microscope, and you see here the glands, the peribiliar glands. These one are the peribilian glands, that can be peribiliar or can be inside the wall of the duct, only on the big duct, extrahepatic bile duct, or big intrahepatic duct, no on the little duct. And you can see here in a scheme. This is a normal situation, the peribiliar gland. This gland produces some secretion that improves the bile flow inside the duct. And the problem is this gland become ill and provoke this cystic formation. So you can see here an explanation. This is a normal situation, the peribiliar glands. And now this is a gland that become ill and make a papillary transformation of his epithelium, and that happened because some inflammatory process make this aggression, as for example, cholangitis, cholestasis, infection by parasitary infection, and even are now reported cases of this type of pathology in alcoholic patient, in a stage of alcoholic cirrhotic patient on the harvested liver after transplant. After transplant, they found 4 or 5 of this type of tumor in the transplanted liver. And it's a report of the pathologist even from Milan, that the name is Federica Pedica, that work in England. And so after this gland became with papillary transformation, produce a lot of mucin, and the mucin go to the lumen of the duct and make this partial obstruction in this patient happen. And after that, arrive to the other side and compromise the other gland from the other side and give this cystic look around the ducts, and in this patient happen. So we can say that intraductal papillary neoplasm of the bile duct is a rather rare pathology. 1354 cases was reported before 2015, almost all from East Country, and now the last publication, that's a review from 2022, speak about only 40 cases confirmed by pathologists and with the look of this type of tumor. So this pathology have origin in the biliary epithelium with intraductal growth or in a peribiliar glands adopting cystic form of this one. 4 histologic types are possible: pancreatobiliary, intestinal, gastric, or oncocytic, as in IMPM. And the new subclassification from the WHO 2019 proposed 2 subtypes, making the relation between the grade of the dysplasia and the architectural change of the layer, of the histologic layer of the duct. And the type 1 is the ones that have low grade or high grade of dysplasia, but with regular architecture. And the type 2 is the ones that have high grade of dysplasia, but with irregular architecture. So, and these ones have a worse prognostic, and the recommendation is be more aggressive with the surgery in these cases. And this is the reason because it's recommended to do a cholangiography and biopsy. So it can be solitary or diffuse, so it is very important to do a cholangiography, again, just to rule out other locations, or maybe a cholangiography, but by the cholangiography, you have now the possibility to take a biopsy and know which of the 2 types is the case that you are treating. Intrahepatic and extrahepatic bile duct involvement are possible. Normally, the extrahepatic have worse prognostic than the intrahepatic. The age of the patient normally is between 50 and 60 years. It is no hereditary problem. It is a premalignant with premalignant pathology with different degree of dysplasia, but almost 60% of resected cases have an invasive component, so it's important to operate. The time of evolution to the cancer is 1 year, so operate always at the moment of our diagnosis. And invasive cases have better prognostic than no papillary carcinoma, so it's a less malignant pathology than the classic cholangiocarcinoma. And it's associated with chronic bile duct infection as chlorhorchiasis or lithiasis. 30% are mucin producer, and remember that the mucin producing, it is impossible to see, to recognize by MRI. And you see here many papers about this subject, and this one is the last review that tried to do a molecular identification of this type of neoplasia, just to have more information and decide the better option, surgical option, to offer to this patient. And this one is a paper that from this pathology from Milan, that work in London, that spoke about the problem of the peribiliary gland as the origin of this pathology, and the reason is, again, the inflammatory aggression, and this provoked the change of the change of the epithelium of this gland and become pathologic. So, okay, that's all.
Thank you, Rodolfo. Well, it's time to finish. Dimitri? Laurence.
Can I ask something? You treat it like a benign tumor because you performed
a local resection.
Local resection.
Yes.
Do you think it's enough for this patient? Because she had a carcinoma.
Yes, it is.
This is my first question. My second one is that I agree, it's very interesting. This is a new entity, not so new, but quite new entity. And I agree with you that it can be multifocal, it can be communicating with the biliary duct, but in fact, for my pathologist, there is two forms. One proximal, like yours, communicating, it's easy to see, and another one, intrahepatic, like cholangiocarcinoma, really peripheral, and it's not communicating, and you can't find. It's the same pathogenesis you showed wonderfully, but it's not communicating. And I agree with the importance of, in that particular papillary form, which is communicating, you have to do a cholangioscopy, graphy, whatever. But in your case, I saw there is a large dilatation of the common bile duct, isn't it?
Yes, but reduce the size from the first images, reduce the size, and was completely normal after, and was about the mucin.
The mucin.
The mucin released by the tumor inside the duct and provoked the obstruction.
And what about now for this patient? Do you intend to reoperate to extend the resection or not?
I answer first the first question of you about the surgery. Only in these cases, because these are two pathologies in one. So, as you say, this is a peribiliary transformation in an EPMB, and the other are the ones that grow inside the duct, no in the peribiliary gland. These one are the ones that you find normally inside the liver, inside the biliary tract, and you don't need to prove the communication. Just in these cases, you need to prove the communication that is from the peribiliary gland. So in these cases that almost are extrahepatic, you have the possibility to do an economic surgery as this one. So it's in the only cases that you can do that. But if not, the idea is to do an aggressive surgery, especially in the type 2 with high grade of dysplasia and disorder of the architecture from the wall. And the only way to know that is by biopsy, by cholangioscopy. So it's for that is recommended to do that. So in relation to what happened with this patient was under follow-up during 6 months. After, well, it was okay. After 6 months, she stopped coming because she lost his social security. And 1 year and a half later, arrived with abdominal pain and with ascites. And he had seeding on the peritoneal and on the epiplum, major epiplum. And the oncologist have said that was not possible that this problem gave that because have any recurrence inside the liver, any recurrence inside the bile duct or around all the biliary tree, and they try to rule out other type of pathology. and nothing was found. The description, the reported about this pathology say that one of the possibilities that you some years ago, or some year, or 1 year, or 6 months, you start to have epipleural implant and peritoneal implant and even lung implant. So the reason I don't know is actually which was the way, but this one was an R0 resection. The progression of this type was really a surprise for us. And this patient was put under protocol, double-blind protocol, that the one branch was placebo and the other branch was durvalumab plus oxaliplatin plus capecitabine. They lived during 22 months else with relatively good quality of life, and after she died. And now we have durvalumab as accepted as first line of treatment, but the conclusion is this is an aggressive pathology, so I think that it's important to try to do an aggressive surgery. Maybe this one was we had the possibility to do this surgery, but sometimes it's recommended make a resection of all the biliary tract, extrahepatobiliary tract, but at the biopsy that we performed of the connection between the tumor and the biliary tree was completely normal, and nothing was evidence inside. And about the lymph node resection, only 8% of the patients have positive lymph node. It is not frequent to have positive lymph node, so in relation to the regular lymph node resection, is not recommended.
Alessandra, the last question?
Yes. Rodolfo,
yes.
For me, your case is fascinating and, let me say, disturbing. I always said that the bile duct is a tube without motility, a little stupid, you know, it's nothing. A tube. And now you say, now it's not only a tube, no. It's a duct inside the gland, which is something for me totally new. What is the normal function of this gland? Mucin? Normally there is no mucin.
Produce some fluid that improve the circulation, the flow of the bile flow inside the duct, and even have some activity in relation to the protection of the epithelial inside the duct. This is the explanation from the pathologist, of course. But this reported is very interesting, very interesting. And you saw the picture from under the electronic microscope. Have a look at the type 2 pancreatic EPMN. It's for that this type of cystic tumor are called branched APMB. Yes, as a type 2 from the pancreas.
So take the message. The bile duct is a gland. It could be, yes, some part in the etiology of the HeLa carcinoma.
Sorry, HeLa?
HeLa carcinoma, you know, the bile duct carcinoma.
Cholangiocarcinoma ileal.
It could be a cholangiocarcinoma? Sorry, I don't understand. Sorry.
No, you know, the common pathology of the bile duct is
yes.
the cancer.
Yes.
What's called the bile duct cancer.
Yes.
It could be this gland has some responsibility in the usual bile duct cancer?
Yes, of course. That happened. This patient have invasion of this part of the duct far to the mucous layer and produce the cholangiocarcinoma, of course. Yes.
Okay, we take the
message. But less aggressive than the classic presentation.
Thank you. It's
Alessandra,
a fantastic case.
Do you want to say something? The last one.
I just wanted to share the similar case that we had with very, very similar radiological images. It actually had multifocal cholangiocarcinoma degeneration from an hepatic fibroadenoma, which have a very similar physiopathology, the one you showed, but doesn't have any communication with the bile duct.
Yes, normally the physiopathology is the inflammatory aggression, whatever was the cause. For example, for the alcoholic cirrhotic patient, the aggression is by the alcohol. I reported 1 year before a case is about patients that work with solvent solution in a puncture fabric, and they find many of these cases. So that support that some inflammatory aggression is the cause of this problem, and that happened the same with the parasitar as chlornorchiasis and the others. And so the phenomena that provoke that is inflammation. So it's necessary to avoid that, to avoid this progression
Okay,
of the tumor.
we have to stop. Thank you everyone for the participation.
Thank you very much.
We are on delay, so we take a break.